After completing the hepatobiliary and liver system in detail, now going ahead and dealing with the renal system. So fluid and electrolyte balance and management in the emergency plays a key role. So we'll be talking in brief about what exactly are the fluids, what are the components, and what are the basic fluid and electrolyte abnormalities that you encounter in your clinical practice, and especially during management of a critical care patient, and how to deal with it. And then we'll wrapping up the discussion by discussing a case related to the presentation. So let's go ahead. So fluid and electrolyte balance is definitely a crucial and dynamic process that is going on, and it is of course crucial for life, and it plays an important role in maintaining the overall homeostasis of the body. So any of the fluid, any of the electrolyte imbalance that can result from either of the cause, which we'll be discussing, can either cause an acute or a chronic illness, and it can also lead to mortality and morbidity. So that's why management and understanding the fluid and electrolyte balance becomes very much important. Now, when we talk about the composition of body fluids, total our whole body weight when we comprise of, so 60% of our body is made up of fluid, and total body weight accounts for 60% of the body fluid. That further are being divided into intracellular and extracellular fluids. So when we talk about the extracellular fluid, it is further divided into interstitial fluid, transcellular fluid, and intravascular fluid. So interstitial fluid accounts for almost 15% of the body weight. Then you have a transcellular fluid, which accounts for, which makes the plasma. And then you have the intravascular fluid, that is cerebrospinal fluid in the brain. So this is the total when we talk about the composition of the body fluids. So when coming to the electrolytes, electrolyte is a body fluid and they are active chemicals. And what are those active chemicals that are there in the body? So active chemicals are composed or contains cations and anions. Even in the school days or even in the chemistry, we have learned that what is a cation and what is an anion. So any positive charge that carries any of the electrolyte is a cation, and any of the negative charge that is being carried by the electrolyte is the anion. So what are the examples of cation when we look into it? So you have sodium, that is Na plus, potassium K plus, magnesium Mg2 plus, and hydrogen ions, that is H plus. When we talk about the anions, you have chloride, that is Cl minus, bicarbonate, that is SCO3 minus, phosphate PO4 minus, and sulfate SO4 2 minus. So these are the cations and anions that forms or that makes the composition of the electrolytes that is there in the body. When we talk about the regulation of the body fluids and compartments, so you have to understand 2-3 terms which are being related to the compartments. The first is the osmosis. So what is the osmosis when we talk about? So any fluid shift that occurs through the membrane, and it occurs from the region of low solute concentration to the high solute concentration until the concentration or until the solution are of equal concentration on both the sides. So region of diffusion or maybe percolation or translocation of fluid from the region of containing low solute to the region of high solute till it maintains an equilibrium on both sides is the osmosis. And why this osmosis term is important? Because whenever there is either a deficiency or excess of electrolytes or any of the body fluids, then this is only the osmosis that plays a role by shifting by either intracellular or extracellular shift of the electrolytes and the various abnormalities. A substance to move from an area of lower concentration to the area of higher concentration, basically. So this is basically the diffusion. So solvent moves by the concentration gradient, which is there, which is present alongside. What is the filtration? So filtration, so there is a permeable membrane and there is a salt water one side and there is a fresh water. So why again understanding these terms, osmosis, diffusion, and filtration, because all the electrolytes and all the key parameters revolve or play around this. So when there is a salt water and when there is a semi-permeable membrane, there is a sheet which is being applied to this area, and salt water contain the salts, that is the sodium, and that even contains all the chloride and everything. So if you apply the pressure and this salt water contain the solutes on this side, so if you apply the pressure and if this is a semi permeable membrane allowing the diffusion of just the water from this filtration or from this slit and keeping this solute on this side, that is holding the solute on this side. So this is the role of semi-permeable membrane, allowing the translocation of just the fluids and keeping the solutes on this side, and you get this fresh water on this side. When we talk about the roots of gains and losses in our body, so 3 to 4 major organs in our body plays a very important and key role when we talk about it. So the first is the kidney, the second is the skin, the third is the lungs, and the fourth is the GI tract. So any of the excretion, elimination of harmful toxic waste products, urea, creatinine, even bicarbonate compensation. So kidneys are a very important and good organ, and even lungs, whatever you inspire, expire, inhale, exhale. So lungs are again important roots of gains and losses of the electrolytes and body fluids. Then you have the skin, that is the largest organ of the body, along with the GI tract that maintains a important, or it forms an important component. When we talk about the fluid volume disturbances, you have hypovolemia. That means the volume of fluid is deficient either in the body, either in the cell. And on the contrary, or on the antonym side of it, there is a hypervolemia in which there is excess of the fluid volume. That is, the fluid volume is present in more than the normal amount. For example, if there is a sodium that is in the range of 135 to 145, so any values less than 135 will be a hypo value, and any values greater than 145 will be a hyper value. So these are the hyper and hypovolemia. So the main electrolyte imbalance which we comprise or which compromise or which consist of are the 3 to 4. You have sodium deficit, less than sodium, which I talked about, that is hyponatremia. Sodium excess, hypernatremia. So when do you call a sodium deficit? When it is less than 135. Sodium excess greater than 145. What is a potassium? Again, what is a potassium deficit? So potassium deficit is known as hypokalemia. So any values less than 3.5 is a hypokalemia, and any values greater than 5.5 is a hyperkalemia. So values between 3.5 to 5.5 of the potassium levels are normal. Then you have a calcium deficit and calcium excess. So any calcium deficit is known as hypocalcemia, and any calcium excess is known as hypercalcemia. So values less than around 8 or 8.2 is calcium deficit, and values of course greater than 10 is a hypercalcemic state which you come across. So what is a hyponatremia when we talk about? So it results from loss of sodium containing fluids or hypoosmolality. That's what we talked about. Movement from low solute to the high solute concentration with a shift of water into the cells. So what are the causes of this hyponatremia less than the sodium? So there are GI loss, which we talked about, 3 to 4 organs that plays a very, very important part in maintaining the fluid and electrolyte balance. So you have GI loss, whether in the form of diarrhea, whether in the form of vomiting or nasogastric tube suctioning. Renal loss of diuretics. So patient is on diuretics, any of the diuretic medications that can even lead to maybe sodium or potassium loss. Adrenal insufficiency, say SIADH, a wasting renal disease, maybe CKD or so. So any of this, cause can be the cause of hyponatremia. If the patient gets excess burns, maybe due to any thermal injury or so, any wound drainage is there, that can also be the cause of skin loss leading to hyponatremia. So what you will do, the medical management of hyponatremia when we talk about, so sodium replacement, because it is a hyponatremia. If the patient is again, who can eat, who can drink, then of course administration of sodium by mouth can be given. But again, if the patient is not able to take through oral feeds, then of course IV access should be advised. Lactate ringer solution. So ringer lactate that contains 0.9% of the sodium chloride is being prescribed. And again, it is very important that rapid correction of serum sodium should not be done. Very important, because it can lead to cerebral pontine myelinosis. It can lead to cerebral edema. So any correction that should not be greater than equal to 12 milliequivalents per liter in 24 hours. Why? To avoid any neurological damage that is being associated with it. So rapid correction should not be done. It should be a slow and a sustained correction. Coming to the hypernatremia, so it is the values that is higher than the normal levels of sodium, that is greater than 145 milliequivalents per liter. Now, when we talk about the causes of hypernatremia, what will be the causes? Either gain of sodium in excess of water, either there is inadequate water intake. So inadequate water intake, more the concentration of solute, and again more retain or more chances of sodium in the body. So increased sodium, serum sodium concentration can also be the causes. When we talk about the hypernatremia, again, it is very much important that gradual lowering. So a rapid correction and a gradual lowering of the sodium level by infusion of a hypotonic electrolyte solution, that is 0.3% of the sodium chloride, is advised. And again, diuretics can also be advised in some case, to maybe prescribed to treat the rapid sodium gain which is being there. Coming to the potassium imbalance. So potassium is the major intracellular fluid cation, with 98% of the body being intracellular. So potassium is critical for many of the cellular and metabolic functions. And again, kidneys are the primary route of potassium load. That is 90% of the daily potassium intake is almost around eliminated by the kidneys. So kidneys again important organ and the primary route of potassium loss from the body that is being eliminated. So hyperkalemia may be caused by a massive intake of potassium. And what can be the cause of hyperkalemia? It can be an excess potassium intake. And what can be the causes of excess potassium intake? Either excessive or rapid parenteral administration can be there. Potassium containing drugs can be the one of the cause. Shifting of potassium out of the cell can be one of the cause. And what can be the cause of movement? Because potassium is an intracellular fluid, so gaining or shifting of the potassium out of the cell because of acidosis, because of any crush injury, because of tissue catabolism, can cause the movement of potassium out of the cell. Failure to eliminate potassium. So failure to eliminate potassium because of the renal disease, because of the adrenal insufficiency, and because of ACE inhibitors, that is captopril, enalapril, that is the antihypertensive medications, can also be the cause of failure to eliminate potassium for the body. So it is not just the renal disease, it is the adrenal insufficiency, it is the antihypertensive drugs. When we talk about the shifting of potassium out of the cell, acidosis, mostly a metabolic acidosis, crush injury, any tissue or muscle crush injury causing the movement of potassium out, tissue catabolism, especially fever. And if you give more of potassium, either through parenteral IV intake or potassium containing drugs, can be the cause of hyperkalemia. So immediate ECG should be obtained. Why? When you talk about hyperkalemia, it can lead to cardiac arrest, it can lead to arrhythmia, and serum potassium levels from vein without IV fluid infusion should be done. So restriction of dietary potassium is advised. Potassium containing diuretic is advised, and IV calcium gluconate can be administered in serum potassium level that are dangerously elevated. Even insulin and glucose mix, that is a GI drip, can also be advised. Even nebulized bronchodilators like salbutamol, that can also help in absorbing the excess of the potassium. So these are the potassium management. When we talk about the hypokalemia, so hypokalemia can result from abnormal losses of the potassium and from a shift of potassium from ECF, that is extracellular fluid, to intracellular fluid or rarely from a deficient dietary intake. So either there is a losses or shift again from ECF to ICF because or rarely because it will cause the shifting or when the dietary intake of the potassium is on the lower side. So potassium loss, shift of the potassium into the cells and lack of potassium intake are the major causes when we talk about the hypo. So if the patient is able to take oral intake, well and good, you give oral potassium. Against IV replacement through, potassium can be given. And again, very much important that, rapid correction. And along with this, you again perform a ECG and of course, monitoring of the patient has to be done time to time. So administer 40 to 80 milliequivalents per day of potassium. When oral administration of the potassium is not feasible, then what exactly is been indicated? Then the IV route is being indicated. So for a patient at risk of hyperkalemia, diet containing potassium should be provided. So very important. So it is either treated with either oral or either IV replacement, and you give a 40 to 80 milliequivalents per day. And when oral route not feasible, go for a IV. And patient who are at a risk of taking more of diet that is not containing excess of potassium should be supplemented. So calcium imbalance, more than 99% of the body calcium is located where? It is located in the skeletal system. So it is the major component of what? Of the bones, teeth, and it helps in strengthening. 1% of the skeletal calcium is exchanged with blood calcium levels. So calcium plays an important role in transmitting nerve impulses, helps to regulate muscle contraction, relaxation, including the cardiac muscle, which is being there. So it plays an important role in the nerve impulses and muscle contraction and relaxation, along with the including the cardiac muscle. Hypocalcemia, so any condition that causes the decreased production of parathormone, that is the PTH, may result in development of hypocalcemia. So what can be the cause of hypocalcemia? Either a multiple blood transfusion, chronic renal failure. Because of that, the calcium levels are being lost from the body because of CRF or CKD. More phosphorus, elevated phosphorus count in the body. A patient is a chronic alcoholic, and because of that, the calcium levels are not being properly absorbed in the body, and because of either mostly a metabolic alkalosis, the calcium levels can be on the decreased side. Now, this is again one of the important sign which is seen with the low calcium levels. And again, if a patient comes to you, Chauvet sign again, and eliciting this Chauvet sign is, again, will give you a diagnosis that the patient is having a hypocalcemia. So you tell the patient to relax his facial muscles, to be light, to stay more of a calm. Then you stand in front of the muscles and tap his facial nerve here, just at the anterior part of the earlobe here, and below the zygomatic arch, which is being here. So, and the corner of the mouth. So basically these are hairs because in front of the earlobe, this is the zygomatic arch, this is the corner of the mouth. And a positive response, if you tap this, if you press this, if the patient have a twitching of the lip at the corner of the mouth, which is elicited in the image, that is due to spasm of all the facial muscles because of the hypocalcemia, and that is a positive Chauvet sign which is being elicited. Trousseau sign is again important, which is seen with the calcium deficiency. So it is in the hand. Carpopedal spasm involves adduction of the thumb over the palm, followed by flexion, that is flexion which is present of what? Of the metacarpophalangeal joints, extension of the interphalangeal joints, that is fingers together, adduction of the hyperextended fingers, and flexion of the wrist and elbow, which is being there. So similar effects can be seen in the joints of the feet also. So this is the carpopedal spasm, which is the adduction of the thumb followed by flexion of the metacarpophalangeal joints, and there is extension of the interphalangeal, followed by hyperextension of the fingers, flexion of the wrist, elbow, and similar effects occur in the joints of the feet, which is also being present. So what will you give if there is a hypocalcemia, the medical management? So IV administration of calcium, either in the form of calcium gluconate, calcium chloride, calcium gluceptate can be given. Vitamin D therapy is also a good therapy that can be initiated because vitamin D will help in absorption of the calcium from the GI tract. And of course, increasing the dietary intake of calcium at least 100 to 1500 milligram per day is important. So increasing the dietary intake of calcium at least 1000 to 1500 mg per day will also help in the medical management of hypocalcemia. Hypercalcemia, that is the excess of calcium, is again a dangerous imbalance. So hypercalcemia crisis has a mortality rate, very important and very, point that should be looked into. So it has a mortality rate as high as 50% if it is not being treated properly. So what is the causes of hypercalcemia if we talk about? So the causes can be either a multiple myeloma, either a prolonged immobilization, overdose of vitamin D, and if the patient is on thiazide diuretics, because thiazide diuretics can even also cause a slight elevation of the calcium levels. So these are the hypercalcemia. So what you will do, the medical management of hypercalcemia? Administer fluids. You have to dilute the serum calcium, and because of the dilution, it will help in the excretion from the kidney. Give IB administration of 0.9% sodium chloride because it temporarily helps in dilution of the serum calcium levels, which is being there. Then along with this, along with this, you can administer the furosemide that will help in increasing the calcium excretion. Calcitonin can also be administered that can help in lowering the serum calcium levels, which is being there. So again, calcitonin is also important. So the body normally maintains a steady balance between the acid that has been produced during the metabolism and the bases that neutralize and promotes the excretion of the acid. So many of the health problems that is being there that are being related to the acid-base balance, in addition to the fluid and electrolyte imbalance. So body is a very good, physiological mechanism. It adapts. And specifically when we talk about, lungs, kidneys, which we have discussed, play a good role in maintaining the acid-base balance. So patients having a diabetes, COPD, kidney disease are more prone to develop acid-base imbalance, which is being there. So what is the hydrogen ion concentration when we talk in terms of acid-base balance? So acidity or alkalinity of the solution is determined by the concentration of H plus ions. Important. So the unit used to describe the acid base is what? It is the pH. And pH ranges between 1 to 4 and a neutral solution of pH measures 7. So normal blood plasma is a bit of alkaline and it has a pH in the range of 7.35 to 7.45. Very important point. So when we tell it is an acidotic condition, so condition that is characterized by more of the hydrogen ions, loss of base ions or bicarbonate in the extracellular fluid, in which there is fall of the pH less than 7.35 because the normal values levels are between 7.35 to 7.45. And when you call it as a alkalosis, it occurs when there is a lack of H plus ions or gain of the base bicarbonate and the pH exceeds greater than 7.45. So body's metabolic process constantly produce acids. This acids helps in maintaining the acid-base balance, neutralization, excretion, and normally the body has three main basic mechanisms by which the acid-base balance is being maintained, and the arterial pH, which is used to calculate the ABG, that is the arterial blood gas, is in the range of 7.35 to 7.45. So these are the three main mechanisms in the body that helps to maintain the acid-base balance. The first is the buffer system, then you have the respiratory system, and then you have the renal system. Very important. So all the three regulatory systems act at different speeds, pace, and buffer generally acts immediately. So respiratory systems, there is a quick response within minutes, and effectiveness is seen within the hours. Then you have the renal response, but renal response generally is comparatively a bit delay or a bit late as we talk about in comparison to the respiratory system, and it takes 2 to 3 days to respond maximally. So alteration in acid-base balance. So acid-base balance is produced when the ratio of 1:20 between the acid and base content is altered. So a primary disease or a process may alter one side of the ratio. So the compensatory process attempts to maintain the other side of the ratio. When this compensatory mechanism fails, this acid-base balance occurs. Very important. So compensatory process that is being there in the lungs, that is being there in the kidneys, try to maintain this ratio. But again, when even that fails, there is an acid-base imbalance. So either an acid-base imbalance, they are being classified as either a respiratory imbalance or either a metabolic imbalance. So let us look into it. So respiratory imbalance affects the carbonic acid concentration, and metabolic imbalance affects the base bicarbonate concentration. So now coming to the respiratory imbalance, the first is the respiratory acidosis. So respiratory acidosis is a clinical disorder, and in that the pH is less than 7.35. PaCO2, that is partial pressure of carbon dioxide, greater than 42 or maybe 45. So the respiratory acidosis can either be an acute condition or it can either be a chronic condition. So what are the causes of respiratory acidosis? Either elevated plasma level, elevated carbonic acid, acute pulmonary edema, interstitial fluid, either a cardiogenic fluid, either a pulmonary fluid, leakage of the fluid into the interstitium, collapse of the lungs, atelectasis zones, impaired respiratory muscles. Because of that, respiratory muscles, proper inhalation and exhalations are not taking place, and there is retention of the carbon dioxide. pH falls, there is respiratory acidosis. So what can the patients will present? Increased pulse, thready pulse can be there. Increased respiratory rate, tachypnea. Increased blood pressure, tachycardia. There is clouding consciousness because of the retention of CO2. CO2 narcosis can set in. There can even occur cerebrovascular vasodilatation, along with increased intracranial pressure, papilloedema. So feeling of fullness in the head can be heavy. So these are the important clinical manifestations that the patient can present. So when we talk about the medical management, treatment is directed by what? Directed by improving the ventilation. Very important. So what are the pharmacological agents that act? The pharmacological agents are bronchodilators. There can be respiratory compromise. There can be airway bronchoconstriction. Antibiotics if there is a secondary underlying infection. Anticoagulants, again, because of the thromboembolism, there are chances of clot in the pulmonary circulations, pulmonary arteries, and maintaining the pulmonary hygiene is important. Adequate hydration. The patient is either put on a non-invasive or a mechanical ventilation, because if the patient is not able to wash out CO2, there is no proper inhalation and exhalation. So then the patient needs a ventilator support for some period of time. Respiratory alkalosis is a clinical condition. So arterial pH is greater than 7.45 and PaCO2, that is the partial pressure of CO2, is less than 38 or 35 mmHg. So what are the causes of respiratory alkalosis? Due to hyperventilation, more of the CO2 is being washed out because there is more rapid and shallow breaths. Anxiety, again, the patient breathes. Hypoxemia, again, the hypoxemia is also an important triggering factor. Chronic hypocapnia, decreased serum bicarbonate levels, and chronic hepatic insufficiency and cerebral tumors can also be the cause. So the patients can present with either a lightheadedness, and lightheadedness can be due to vasoconstriction. decreased cerebral blood flow, there can be numbness, there can be tinnitus, the loss of consciousness can be there. There can also be tachycardia along with ventricular and arterial dysarrhythmias, which is there. So how you will manage this respiratory alkalosis? Treatment generally depends upon the underlying cause. So if the patient is having anxiety, the patient is allowed to take, breath more slowly, allowing more accumulation of CO2. Sedatives can also be given, maybe opioid, non-opioid sedatives, to relieve that hyperventilation, to relieve that anxiety in very anxious patients. Metabolic acidosis is a clinical disturbance that is being characterized by what? Low pH. That is more of hydrogen ions, low plasma bicarbonate concentration. So a gain of hydrogen ions or a loss of bicarbonate. And it can be divided into two forms according to the values of the serum anion gap, which is being there. So what can the patient can present to you in metabolic acidosis? There can be headache. He can present as confusion, drowsiness, more of the respiratory rate depth, nausea, vomiting, the blood pressure can be on the lower side, dysarrhythmia, shock, cold and clammy skin can be there. So what you will do, the diagnostic findings, if you do a ABG analysis, you can see a low bicarbonate levels less than 22, a low pH less than 7.35. ECG, if it done, can detect dysarrhythmias that can be caused due to increased potassium levels. So treatment, correct the metabolic defect. If problem results from excessive intake of chloride, treatment should be aimed at maintaining the elimination of the chloride. So bicarbonate is administered if the pH is less than 7.1. So serum potassium levels is being monitored closely. Hypokalemia is corrected as acidosis is being reversed. Metabolic alkalosis is a clinical disturbance characterized by high pH, that is decreased H plus ions, and a high plasma bicarbonate concentration. So produced by either a gain of bicarbonate or a loss of H plus ions. So what can be the causes of metabolic alkalosis? Either a vomiting, gastric suction, nasogastric, orogastric, resulting in loss of hydrogen and chloride ions. If there is pyrolic stenosis in the stomach, diuretic therapy that promotes the excretion of potassium from the body, a genetic condition known as cystic fibrosis, chronic ingestion of milk and calcium carbonate can also be the cause of metabolic alkalosis. So the patient can present with tingling, dizziness of the fingers, toes, and symptoms of hypokalemia is often the symptoms of the alkalosis. So ventricular disturbance can be there if the pH increases above 7.6. So sufficient chloride must be supplied for kidneys to help absorb sodium with chloride. Give sodium chloride fluid, H2 receptor antagonist like cimetidine that reduces the gastric HCl, decreases the metabolic alkalosis that is associated with gastric suction should be done, and input-output charting should be closely monitored. So these are the, when we talk about the medical management of the metabolic as alkalosis. So we have, now let us go and discuss one of the case which is being related to this PPT which we have discussed. So we have discussed we'll be wrapping up what we till now what we have discussed. So there is a patient, Mr. X, he's 60 years male. He's a shopkeeper by occupation. But again, if we talk about the background illness of the patient, he is having a type 2 diabetes mellitus, which is present till almost 10 years. He also has a hypertension history of 5 to 10 years. When we talk about the drug history of the patient is on thiazide diuretics for the control of the blood pressure, just thiazide diuretics. So the patients presented to the emergency or in the critical care setup with repeated vomiting, and this repeated vomiting is being present since what? Since 3 days. So there is generalized weakness, there is fatigue also present. There is altered sensorium, which is present since morning. Muscle cramps and tingling sensation in the hands are being present. And there is reduced oral intake and decreased urine output which is being there. So repeated vomiting, generalized weakness, fatigue, altered sensorium, muscle cramps, tingling, and reduced oral intake and decreased urine output is being seen in the patient. Very much important. Now let us look at the HOPI of the patient. So the patient was apparently well 3 days ago when he developed multiple episodes of vomiting. And what is this multiple episodes of vomiting? This multiple episodes of vomiting is maybe due to suspected food poisoning, any food intake which he must have consumed. So he continued taking his, antihypertensive medications, including the diuretics. But over the next 48 hours, this patient develops what? Weakness, which is increasing dizziness and confusion. So there is no history of fever, there is no history of diarrhea, there is no history of chest pain or seizures which are being present. When we look at the relevant past history in the patient, as we discussed, is a known case of diabetes mellitus. He's on oral hypoglycemics. Hypertension, he's on thiazide diuretics. There is no history of chronic kidney disease in the patient. And there is no alcohol intake history also, which is there in the history of present illness. So when we evaluated the patient, when we did his physical examination, on general examination, the patient was drowsy, but the patient was arousable. Signs of dehydration was seen. The patient was having a dry tongue. The patient was having a poor skin turgor. And even the skin or was lifted, and it was, because of the dehydration, that was very slowly going back to its normal position. The pulse, he was slightly on the higher side, tachycardia 110 per minute, but it was a regular pulse. A BP was on the lower side of 90-60. Respiratory rate of higher side 26 per minute. Deep breathing was there. So on systemic examination, cardiovascular tachycardia was there. Increased pulse, but there was no murmur. Respiratory revealed a deep, rapid breathing. Neurological signs showed signs of confusion, tingling of fingers, and a positive Chvostek sign, which is being present. That means the patient must be having what? Hypocalcemia also. So a provisional diagnosis of fluid volume deficit with mixed electrolyte and acid-base imbalance was being made. We also send a couple of laboratory investigations in the patient, and serum sodium levels was in the range of 128, that is less, that is hyponatremia. Serum potassium levels was also less, that is 2.9, hypokalemia. Serum calcium was also less, 7.4 mg per deciliter. Hypocalcemia. So hyponatremia, hypokalemia, hypocalcemia. Kalemia, natremia, most because of the thiazide diuretics. Serum bicarbonate also less, 80. And blood pH was also decreased, 7.2. PaCO2 was also decreased, 30. And anion gap was still normal. Creatinine was mildly elevated, and ECG, which was done, it showed flattened T waves and U waves. So a final diagnosis of hyponatremia due to the GI losses and diuretic use was being made. Hypokalemia due to the vomiting and renal loss. So GI lysis diuretic can be the cause of hyponatremia, which we have discussed. Hypokalemia because the patient has persistent levels of vomiting, and this is present since 3 days, and renal loss is also being there. Hypocalcemia secondary to alkalosis and electrolyte shifts. Metabolic acidosis, normal anion gap with respiratory compensation, and fluid volume deficit is being seen. So when we compare the pathophysiological correlation of this patient, till now we have discussed. So vomiting in this patient results in what? Results in loss of hydrogen, chloride, sodium, and potassium. Diuretics, as the patient is on diuretics for his antihypertensive medications, results in renal potassium and sodium loss. Dehydrated, there is reduced renal perfusion. Electrolyte imbalance, neuromuscular irritability, and cardiac changes. And metabolic acidosis, increased respiratory rate. So metabolic acidosis can be there, leading to the compensation. So what we did, the immediate management of the patient, because we have to stabilize the airway, we have to look for the breathing, and we have to look for the circulation. So the golden rule of A, B, C, D, E that we have discussed when we discussed the respiratory system. So airway, breathing, circulation, disability, and exposure are important. Continuous ECG monitoring is important because of the patient having hypokalemia. So fluid management with IV 0.9% sodium chloride was being done to correct hypovolemia. Strict input-output charting was being advised. So electrolyte correction, hyponatremia, because gradual sodium correction has to be done. Greater than 12 milliequivalent in 24 hours. Why? Because as we discussed, it can lead to cerebral pontine myelinosis, cerebral edema. So sustained, slow, gradual correction of the hyponatremia, sodium level should be done. Hypokalemia, either oral or IV potassium replacement in a range of 42 mg milliequivalents per day under the ECG monitoring. Hypocalcemia, IV calcium gluconate and vitamin D supplementation for better absorption of the calculation, and encourage a dietary calcium of how much? 100 to 1500 mg per day. Acid-base management. So treat the underlying cause. Treating the cause because the patient is having vomiting, so anti-emetic drugs, dehydration. Bicarbonate therapy should only be prescribed if pH is less than 7.1. So pH was generally around 7.2 in our case. Monitor the ABG and serum electrolytes at a serial level. A supportive care should be done, and stop diuretics temporarily because the patient is having hypokalemia, hyponatremia also. Antiemetics can be done, given for vomiting, and adequate hydration should be done, and monitor the renal function accordingly. So what outcome and follow-up was being done in our case? Gradual improvement in sensorium because of the sodium loss, because of the, because of the CO2. So normalization of electrolytes was being seen over 72 hours. Discharge with the dietary advice and medication review was being done with the patients. So what key learning points we have seen from our case? Fluid and electrolyte balance is very much important, dynamic and vital for maintaining the proper homeostasis. Electrolyte correction must be gradual and it should be monitored. Acid-base imbalance often coexist with fluid disturbance, and early recognition prevents the life-threatening complications which is being there. So this is the bibliography. So this was all about the case management which we discussed related to our presentation, and important when we talk about all the electrolyte abnormalities which we have discussed. So you have to understand a few of the important terms. Hyperkalemia. What exactly are the electrolyte imbalance? When we talk about hyponatremia is important. Hypernatremia. What is potassium imbalance? Either a hyperkalemia or a hypokalemia. What is the medical management? Calcium balance, when we talk about either a hypocalcemia or a hypercalcemia. What are the Chevos-Stokes and Trochu sign? So, and coming to the acid-base management. So what exactly is the hydrogen ion concentration? What is the acid-base regulation? What can be the alterations in the acid-base balance? And two more main acid-base imbalance are the respiratory and metabolic imbalance. So you have respiratory acidosis, clinical manifestations, medical management. You have respiratory alkalosis, clinical manifestations, medical management, and diagnostic findings accordingly. So this was all about the fluid and electrolyte imbalance and management in the emergency. Thank you. Yeah.